this nice introduction, and we have a very busy day ahead of us today. A very full webinar full of QST and phenotyping studies that I'm going to present, and I am not able to put all the QST and phenotyping studies that I wanted to present. So please forgive me if there is one that you missed. In any case, be so kind to fill up at the end at the survey and let us know how we did. And if you need any further attention, we would be happy to correspond with you through email. So what we will talk about today, we will talk about a little bit about quantum sensory testing. For those who are a little bit less familiar, I'm going to go through what static QST and dynamic QST is, and we will also touch upon what phenotyping is. The major part of this presentation will be about the roles of QST and phenotyping, and we will talk about disease and condition phenotyping, about the phenotyping and disease development, about development of neuropathy and chronic pain, about phenotyping and drug efficacy and how QST can assist in this, about post-operative outcomes, and non-pharmacological and interdisciplinary treatment efficacy. So let's start. Basically, what is QST? QST is quantitative sensory testing, and this is a test which is in which a standardized sensory stimulus is offered to a test subject, and a behavioral response is obtained based on the appropriate sensation. And we have to keep in mind that this is a subjective test, and for this we need a very correct and consistent methodology and instruction, which are very, very important in order to get the right response from the patient or the subject and to get repeatable results. In static QST, and we will talk mostly about these subjects, but other subjects will also come, we will talk about warm sensation, cold sensation, and pressure, and the different varieties of the sensation that we have. For instance, in warm sensation, we can encounter the warmth detection threshold, the heat pain threshold, and the heat pain tolerance, and the same with cold. So we can encounter cold detection threshold, the first moment that you feel that the temperature has changed toward cold. The cold pain threshold, the first moment that the cold has become even the slightest painful, and cold pain tolerance is the last intensity, the highest intensity that the subject can tolerate. And in pressure, we will encounter pressure pain threshold, the first moment that the pressure is becoming painful, and pressure pain tolerance, the highest intensity that the subject can tolerate. And the three dots at the right also represent other modalities, for instance, electrical thresholds, vibration thresholds, and these will be touched upon later in this presentation. When we go through the different types of thresholds, as I said, the sensation threshold is the first temperature, for instance, in which the patient is able to sense a specific stimulus. The pain threshold is the first temperature intensity where the stimulus becomes painful, and then the pain tolerance is the highest temperature intensity that the patient can tolerate. And when we examine the results of sensation and pain thresholds, we can compare them to a large amount of data. Sometimes we can take a control group, or we can compare them to known normative data that have been gathered with the same devices and methodologies. And when we do such comparison to age and gender matched normal controls, this is called normative data, and based on these comparisons we can come to conclusion about the test results. For instance, around the sensation thresholds we have hyperesthesia, meaning that a person senses something before their peers. This is something that we don't see a lot, or it's not very practical in, for instance, thermal threshold, but hypoesthesia is. So this is a person that will sense, for instance, a cold sensation later on at a lower temperature in comparison to their peers. Allodynia is when stimulus is experienced as painful while the stimulus is non-noxious. And a normal day-to-day example of allodynia is that when you have a terrible migraine, then even having your sunglasses on may be painful here on your nose or on your ears. So this is allodynia, a non-painful stimulus which has become painful. In pain thresholds, we have hyperalgesia, which means a lowering of the pain threshold. So this is somebody will feel it a stimulus earlier than their peers, and also hypoalgesia, so they will be less sensitive to a painful stimulus. I want to talk about this subject because the DFNS, the protocol, the DFNS is the Deutsche Volksverbund Neuropathischer Schmerz, and this is the German research network for neuropathic pain, and they have been very, very busy for many years now in QST and how QST can help us typify what's going on with a specific patient in terms of the somatosensory nervous system. And they have a standardized protocol with different modalities to test different afferent nerve fiber functions. So when we go to the A section on the top left, these are the thermal, this is the thermal part of the protocol, and we will start with cold detection, 3 stimuli, warm detection, TSL, thermal sensory alignment, and paradoxical heat sensation. This is an up and down stimulus, cold pain threshold and heat pain threshold, and each of these stimuli is done 3 times, and then they go over, and as part of their device that they use is also the MEDOX TSA2, so that's good news for us. And now with the B and the C, mechanical detection threshold is done with von Frey. Mechanical pain thresholds, mechanical pain sensation are done with the pinprick. Allodynia is tested with a Q-tip. Wind-up ratio is tested again with a pinprick, and vibration detection threshold with a tuning fork, and pressure pain threshold with a pressure algometer. And why am I going into the subject so very much? Because later on in this presentation, we will encounter several studies in which the DFNS protocol has been used. So that's why I want you to be aware of the protocol and know what the type of modalities appear in this protocol, so we know what we are talking about later on. So when we talked about static QST, we often talk about sensory nerve function. We are looking at very specific into function, but when we are going into dynamic QST, we often talk about pain processing. And when there are 2 different paradigms that are often used when looking at pain processing. And the first is conditioned pain modulation. And conditioned pain modulation is a psychophysical measure to test the ability of the ascending inhibitory pathways in a simulated setting. And this is the human correlate to the known animal phenomenon of diffuse noxious inhibitory control. And if I have to say it in a layman's terms, it would be pain inhibits pain. Okay, so let's take an example. I have a terrible migraine, and I'm walking out of my bedroom, and I knock my toe into the counter of the kitchen, and suddenly I don't feel my headache anymore. So this is a pain inhibitory mechanism. Pain inhibits pain, and later on we'll explain to you a little bit how this is done in the lab setting. We want to look at facilitation or central sensitization. We often use the temporal summation protocol. And the temporal summation is a psychophysical human correlate for the wind-up phenomenon, which we see in animals. And this is in which we give a repetitive or a tonic same intensity noxious stimulus from the periphery, and it is being experienced as more and more painful while the stimulus stays the same. If I have to give you an example about conditioned pain modulation, again, we usually do give 2 different stimuli. One test stimulus, which is given separately, standalone. And in this case, I gave you the example of a thermal test stimulus, for instance, and we asked the subject to rate this test stimulus. And for instance, this time the subject rated it on the VAS 0 to 160. And now we administer a conditioning stimulus, and this could be, for instance, a cold pressure test. So it's a very robust conditioning stimulus. And during the conditioning stimulus, or right after the conditioning stimulus, we give another test stimulus. And this time, if we have an effective CPM, conditioned pain modulation, and descending inhibition going on, we will see that the same stimulus will be rated lower in its intensity. And then we can say the CPM efficacy in this patient was -40, and the more negative, the better. And this is just an example. You can do CPM in with different types of modalities, and we will talk about that later on when we will encounter them in those studies. In temporal summation, we give, for instance, 10 repetitive, very short and in high frequency stimuli, and we ask the patient to rate, for instance, the first and the last, and we can see the delta between the first and the last. And the higher the delta, the more facilitation is going on with this subject. Okay, now that we talked a bit about QST, let's talk about phenotyping. And the word phenotyping first appeared in somewhere in the 1800s when used by biologists and botanists, and they talked about why a specific plant behaves in a specific way, and this has something to do with the genetic makeup of this plant, but also with how much sunlight and how much water and what other plants are in the area. So that's the first mention of phenotype. And when we talk about phenotyping in medical sciences, we talk about an observable trait, and we want to see what a specific disease or condition, what qualities it has. So let's continue on to disease phenotyping or condition phenotyping. And I want to present to you this study by Ratupova, and this was a cooperation between the University Hospital of Brno in the Czech Republic and Würzburg and Mainz in Germany. And they aim to objectify why some patients with diabetic neuropathy suffer from pain and why others don't. And they collected clinical as well as neurophysiological data from a very large cohort of patients with confirmed or suspected diabetic neuropathy. The cohort consisted of 232 patients with definite diabetic distal symmetrical sensorineural polyneuropathy, and let's say that's very shortly DSPN. And these patients were allocated into 3 groups based on the mean pain intensity during the last week. So either the no neuropathic pain group, they had 0 pain. The mild neuropathic pain group, which had a VAS between 1 and 3 in the last week, and the moderate to severe neuropathic pain, and those had a VAS between 4 and 10 in the last week. These patients underwent standard neurological examination and QST according to the DFNS protocol. And here we have it, the DFNS protocol that I talked about earlier. Okay, so this is the terminal part of the DFNS protocol, and here we can see the painless, the mild pain, and the moderate to severe pain patients and how they differ from each other. And you can see that there are significant differences in their thermal sensory perception for cold detection, warm detection, thermal sensory alignment, cold pain and heat pain. And so we can see that the differences between the non-painful diabetic neuropathy, the mildly painful diabetic neuropathy, and the severely painful diabetic neuropathy. And also here, the comparison between the subgroups of patients with painful diabetic neuropathy in the different sensory QST profiles, and it showed that the deafferentation profile, so the patients that don't sense a lot in terms of at least thermal sensation, had a higher severity of neuropathy and a longer duration of pain. And these people were predominantly patients with in the differentiated QST profile with painful diabetic neuropathy, the frequency and the severity of the terminal loss were correlated not only with the presence and severity of neuropathic pain, but also with the severity of neuropathy and disability. To go to a totally different type of setting, and I'm very happy to show you all these different types of researches, because everybody does something else in the lab. Everybody is focused on a different type of patient group, and I'm always happy to expose you to other types of researches that have been done with QST and that have been around. So this is a study by Hellman and al. From the North Shore University in Evanston, Illinois, and they studied dysmenorrhea. And dysmenorrhea, for those that have to look it up myself, is pain associated with menstruation. So they researched the subject because of the association between dysmenorrhea and the risk of developing chronic pelvic pain. And they included women who rated the menstrual pain more than 5 out of 10 without the presence of other chronic pain. And what they did in this study, they used pressure pain thresholds, which they measured at 4 transvaginal pelvic floor sites and extravaginal sites like the right trapezius, the right medial knee fat pad, and the right greater trochanter. And they also did CPM, and in this CPM, they used the test stimulus as pressure pain threshold at the knee and at the shoulder, and the conditioning stimulus was called pressure test to the hand. And temporal summation they also did with pressure algometry at the medial knee. And as you can see, they had 37 healthy controls, 98 women with only dysmenorrhea, 49 women with dysmenorrhea and bladder pain, and chronic pain without bladder pain syndrome, and women with bladder pain syndrome. And the bladder pain sensitivity was assessed by doing a bladder filling task. So this is the way they looked at it. The dysmenorrhea participant had lower vaginal pressure pain threshold at 2 sites and after pain sensation as compared to the healthy controls. And compared to the healthy controls, the dysmenorrhea participant had also dysmenorrhea and bladder pain syndrome participant had significantly lower vaginal pressure pain thresholds at all sites and significantly worse after pain sensation. The dysmenorrhea patients reported more cold pain than healthy, but otherwise were not significantly different in pressure pain thresholds in other body sites or in temporal summation and CPM. The dysmenorrhea and bladder pain patients had a less efficient CPM compared to the healthy controls and to dysmenorrhea patients. And I wonder what these researchers found out of this study, because you would say that if you look at their pain threshold, the dysmenorrhea bladder pain patients have also widespread pain to other parts of the body, but they are not like the bladder pain syndrome patients. And this is an interesting finding, and I wonder what the next study from this group will be. I want to talk about, not about pain syndrome, but about autism. And in autism, we know that DSM-5 specifically states that we can expect differences in somatosensory processing, for instance, higher or lower sensitivity to pain. And in this interesting study by Hoffman et al. From the Rambam Healthcare Campus and Haifa University here in Israel, they looked at pain processing of 52 adults with autism and 52 healthy controls with comparable IQ. And in terms of QST, they did cold detection, warm detection, and heat pain threshold using Maddox TSA2. And they also looked at heat pain sensitivity to phasic stimuli and thermal temperature summation, which were tested with Maddox pathway CHEPS. And at the CPM, they did a phasic CPM in which there were several short stimuli, and in this they used the pathway CHEPS, but they also did a tonic CPM in which the test stimulus was a tonic heat pain stimulus, and this was done with the TC2. And the conditioning stimulus was performed with a hot bath at 46 degrees. And as in terms of the results, the thermal thresholds were calculated according to Z-scores, and there was no difference that was found between the autism subjects and the controls. So this is interesting. Are we debunking the theory that autism subjects are less sensitive to pain? Let's look at their pain ratings to the 5-6 superthreshold stimuli. So they did that with 3 different temperatures, very short painful stimuli, and you can see that the autism group rated these stimuli much higher than the controls, and this is an interesting finding. So maybe there is a heightened sensitivity to pain. In terms of temporal summation, both the first and the last stimulus were rated significantly higher in the autism group. However, neither of those groups, nor the autism nor the controls, showed a temporal summation effect, and this is not shown in the graph in the table here. The table here is regarding CPM, and the phasic CPM. Both groups showed effective CPM, and you can see that here on top. But in the tonic CPM at 20 seconds, so the stimulus is lasting for a while, and 20 seconds into the stimulus, there's a significant difference between the groups in terms of pain inhibition, and we can see that the controls have effective CPM and the autism group does not. So these are interesting findings and an interesting place to start from in looking at pain sensitivity and pain processing in autism subjects, and I'm very grateful for this amazing study by Hoffman et al. I want to introduce to you, going back to neuropathic pain, this very big study that was done on a test cohort of 92 patients with a validation cohort of 233 patients. And this is data that was gathered by the DFNS, as well as the Neuropain Europain database. And Hoffman suggested that patients with neuropathic pain could be subgrouped according to a specific QST profile or a specific pattern in the QST profile. And they found that the results could be arranged according to the clusters and specific sensory patterns. And I want you to look at the colors separately, okay? So let's look at the blue, and the blue is the cluster for sensory loss. And we look over here at the cold detection and warm detection, and these are patients that have severe sensory loss for these thermal modalities. And we also do see some sensory loss for mechanical modalities as well as for vibration. Okay. Now let's go over to the red group, and this is the thermal hyperalgesia group, and they are characterized by preserved sensory function, and we can see that over here. So we have preserved sensory function in terms of heat and cold sensation, but we do see heat and cold allodynia, and we just crossed the 0 of the Z line, so now we are at a gain of function. And there is also some mild dynamic mechanical allodynia going on. And the yellow group, as last, is characterized by loss of small fiber function. So these are again the cold sensation, warm sensation, but this is also in combination with hyperalgesia to pinprick and dynamic mechanical allodynia. And you can see the test data set, which consisted of 902 patients, data from 902 patients, and a validation data set, which consisted of 233 patients. And you can see that they more or less align. So this is a way indeed to look at different patterns of behavior in terms of QST. And you can see that the database contained data from different types of patient groups, from different neuropathy etiologies. So we can see polyneuropathy and radiculopathy and peripheral nerve injury. And we can see also how much of each type of pattern appears in a specific etiology. And you can see that even though we have different types of etiologies, there is you cannot really say, oh, radiculopathy, you can only see this type of pattern, not this type of pattern. You have all types of patterns in all types of etiologies, and this is an interesting way to look at it. And this is another way to look at it. In this slide, we find the frequency of results per cluster, which fell outside of these 2 standard deviations from the norm. So you can say about the sensory loss, the mechanical hyperalgesia and the thermal hyperalgesia are very different from these that you can see. Very normal small fiber function, but thermal hyperalgesia in this. I want to take you along with me to the next subject, which is disease development. And we will talk specifically about diabetes, because in diabetes we can see all kinds of systems functions breaking down, and can we find future damage by diabetes through QST? I say we can. And this study by Fang et al. From the Keelung Chang Kung Memorial Hospital in Taiwan, they are avid QST users, and they had a cohort of 432 patients with type 2 diabetes, and QST was done on all 4 limbs, and they used Maddox's previous vibratory device, the VSA 3000, and a TSA for thermal testing. And the presence of diabetic kidney disease was identified by assessing albuminemia and eGFR, and patients were defined as having advanced diabetic kidney disease if they had an eGFR of smaller than 45 milliliters. And they also looked at peripheral artery occlusive disease, and this was diagnosed according to the ankle brachial index, and it was defined as the lowest value of the right and left ABIs, as measured by Doppler ultrasound, and peripheral arterial occlusive disease was defined as an ABI of less than 0.9 or more than 1.3. And the histograms show the percent of patients with abnormal findings divided by the diabetic kidney disease stage. And if I can assist you in reading these histograms, LLs is lower limb, called perception abnormalities, and then we have warm perception abnormalities, upper limb, and here in this we also have forelimb cold perception and warm perception abnormalities. But that cuts to the chase. When we look at what is a definitive factor in order to predict advanced diabetic kidney disease, we need to look at lower limb cold perception abnormalities. And the authors of this study recommend that based on QST, renal values should start being monitored as soon as we see lower limb cold perception abnormalities as well. Continue on in diabetes. Quantitative sensory testing can effectively predict cardiovascular autonomic neuropathy in patients with type 2 diabetes. And this was a study that was conducted in the Nanjing Drum Tower Hospital in China. And QST was performed using Maddox's pathway on the dorsal of the foot, and they used a very large patient cohort of 266 patients. Type 2 diabetes, and they looked at the cardiovascular reflex tests, and they're called CARTs, and CARTs included 4 components: the Valsalva maneuver, the heart rate response to deep breathing, the blood pressure response to standing up, and heart rate response to standing up. And cardiovascular autonomic neuropathy was scored according to the cardiovascular reflex test. So diabetes with 1 point on the cards was no cardiovascular autonomic neuropathy, and diabetes with between 1 and 2 points of cards was early cardiovascular autonomic neuropathy, and with more than 2 points was diabetes with autonomic neuropathy. And we can see that we have a difference between those with cardiovascular autonomic neuropathy and those with no cardiovascular autonomic neuropathy in all of these measures. So warm detection threshold, heat pain threshold, cold detection threshold, and cold pain threshold as well. And if we have to look at the prediction values of these measures, we can see quite high sensitivity and a little bit lower specificity. But you may be interested in what measures can predict the development of neuropathy and chronic pain. And a very classic example of predicting neuropathy is in CIPN, in chemotherapy-induced peripheral neuropathy. And we can see that with several of the chemotherapy agents that are used, that have different effects on the central and peripheral nervous system. And in this study by Reddy et al. From 2016 from the Northwestern University and the Robert H. Lurie Comprehensive Cancer Center, patients with gastrointestinal malignancies were scheduled to start oxaliplatin regimen. And they did QST at different time points. At the baseline, before starting cycle 1 hour into oxaliplatin infusion. So imagine that doing QST during chemotherapy infusion, immediately before cycle 2. So this is 2 weeks into the treatment, immediately before cycle 4, 6 weeks into treatment, immediately before cycle 12, which is 22 weeks into treatment, and with a 1-year follow-up. And they looked at mechanical sensation with von Frey and sharp mechanical pain with NeuroPen. And they used Manox DSA to perform thermal QST, cold sensation, warm sensation thresholds, cold pain and heat pain. And cold and warm allodynia were defined as having cold or heat pain temperatures respective that were more than half a degree of standard deviation from age and sex matched norms. And manual dexterity was tested used as a 9-hole peg test. And they started the study with 57, but at the end of final analysis was done on 19 patients. And they found that patients having higher heat detection thresholds, which this means that they at a higher temperature, they only felt the heat during the infusion, and a higher cold detection threshold during the infusion were more likely to experience grades 2 and 3 of neuropathy. And if you can look over here on the right, what grades 2 and 3 means, this is a severe a problem in sense of limiting instrumental ADL or having pain or severe pain. And this table, excuse me, I ran ahead. And this table shows that at baseline and during the first infusion, we already have strong correlations between the thermal QST variables and grades 2 and 3 neuropathy at 1 year. Next study, also on CIPN, and again with oxaliplatin from Koigat, and I really hope that I'm saying this correctly, and please forgive me if not, from the South Danish University of Odense. And the aim was to evaluate the predictive value of skin biopsy, of QST according to the DFNS protocol, and of nerve conduction studies. And they had 55 patients who were eligible to receive oxaliplatin therapy due to colorectal and esophageal cancers that completed the study. And they found that the change in cold detection threshold after 25% of the treatment was a predictor for having neuropathic pain as measured by the neuropathy pain symptom inventory at 6 months after ending treatment. And also the vibration detection thresholds at baseline were an indicator for neuropathy 6 months post-treatment as measured by the reduced total neuropathy score. So this is to keep in mind, and maybe there is a way to protect specifically these patients that at baseline are different and should be kept an eye on. And maybe there's a way to protect them against these damages. On a totally different subject, I want to take you with me to the intensive care unit. And this is a study by Baumbach et al. From 2018, and they did it in the Jena University Hospital. And they found that about a third of the patients released from ICU suffer from chronic intensive care related pain, and it's unknown which factors could influence the development of chronic intensive care related pain. And for this, they wanted to use a pain measure, which was the German Pain Questionnaire, at 6 months, at 12 months. And there were subscales that were analyzed, like pain intensity in the hospital and anxiety and depression scale, and in the SF-36. And the QST was performed at 6 and 12 months post-discharge, according to the FNS protocol, on the dorms of both hands. So these are people that already were in the intensive care, and afterwards we are doing QST on them. And we can look how they differ from those between each other, which was painful and which was painless. And they found that 6 months after discharge from the ICU, there was data available for 197 patients, of whom 77 did QST, and 12 months after discharge from the ICU, there was data available for 159 patients, of whom 55 did QST. And they found at a lower age, a female sex, lucky us, higher levels of inflammation and average pain ratings of higher than 4 on the NRS in the 4 weeks after the ICU discharge were associated with higher risk of CIRP. And patients with small fiber elasticity in terms of warm and cold measures were at a high risk also for developing chronic intensive care related pain. So that is in terms of disease and neuropathy and pain trajectories. Now let's look at drug efficacy. And I'm sure many of you may be very, very curious about this subject, because how can we help our patients better in getting the right treatment right away instead of trial and error, which is often being done. And a classical study that I want to present to you on this subject from 2012 by the Anitsky lab in the Technion in Haifa and also Rambam Medical Center did QST and CPM on 33 patients with painful diabetic neuropathy who had pain at least 40 out of 100 on the VAS scale in the past month. And they had 2 experimental sessions, a pre and a post-treatment, and the treatment protocol consisted of 1 week inactive placebo and 1 week duloxetine of 30 milligram, and then 4 weeks of duloxetine of 60 milligram. And the duloxetine, for those who don't know, is a serotonin noradrenaline reuptake inhibitor agent, SNRI, and QST for detection of pain threshold and sensation threshold was performed at the dorsal foot, and the test stimulus was done with the Medox TSA and the contact heat, and they use also CPM, and there the test stimulus consisted of contact heat of 40 seconds at the level of pain 60, and then 15 minutes apart. The conditioning stimulus consisted of a hot bath of 46.5 degrees for 60 seconds, and temporal summation they did with the thickest one fry for 10 repetitions. And they found that less efficient CPM correlated with better drug efficacy as rated by the patients. And equally, less efficient CPM was significantly correlated with pain reduction. And in terms of the change in CPM, so we can see that the drug also had its effects on these measures of CPM and temporal summation. We can see that CPM improved those that had less effective CPM, even summation, improved, or you can say almost say normalized, and indeed it was also so with temporal summation. So those who had a lot of facilitation also improved following treatment. Keeping with duloxetine, I want to present to you this study by Peterson et al. From 2022 from Aalborg University in Denmark, and they had 22 patients with unilateral and bilateral knee osteoarthritis in a blinded crossover study of 18 weeks of duloxetine with a maximum dosage of 60 milligrams per day, followed by placebo or vice versa. And their QST consisted of cuff pressure oximetry, so this is also one of the options, and pressure pain detection threshold. They did with that, and pressure pain tolerance was also measured, and temporal summation, also again with cuff pressure oximetry, 10 short pressure pain stimuli. And CPM was measured as a change in pressure pain detection threshold with a tonic cuff pressure conditioning stimulus at 70% of the pressure pain tolerance. And we can see in model 2, so they did model for predictions, and they found that an independent predictor of duloxetine efficacy was the contralateral pain detection threshold and temporal summation of pain. And those were independent predictors and really dependent on which measure you look at. So whether you look at only worst pain or you look at average pain, WOMAC, which is a very accepted measure for osteoarthritic pain in general. Going on different subjects, Meinka et al. From the Ruhr University in Bochum, Germany, had an interesting study about the efficacy of applied capsaicin patch on patients with peripheral neuropathy of different etiologies. And they used the full DFNS protocol, and they treated only one leg, and they wanted to, check for effects between one leg and the other. And the capsaicin is a TRPV1 receptor agonist, and it is used to treat neuropathic pain for those who are unfamiliar with this treatment. And it was applied on the painful area for 60 minutes, and there was 1 visit before application and 4 follow-up visits up to 8 weeks after application. And in total, 20 patients were treated, and all patients had their pain decreased. But 10 of them were responders who showed a maximal pain relief on average of 2.6 points on the NRS, and notably those who had cold pain threshold and mechanical pain threshold that are in terms of gain of function, they were predictive of responders. This is something to keep in mind. Meinka actually wrote that responders could be identified by the sum score of the Z value of the cold pain threshold and the Z value of the mechanical pain threshold of more than 0.8, with a sensitivity of 70% and a specificity of 100%. So good news for those who have gain of function in the cold pain threshold area and the mechanical pain threshold. I want to present this study by demand out of 2014, and this was done in the Odense University Hospital and the Danish Pain Research Center in the Aarhus University Hospital, and they recruited patients with neuropathic pain due to polyneuropathy, peripheral nerve injury, and post-operative neuralgia. And the treatment was, and hang on with me, oxcarbazepine, and this is an anticonvulsant which exerts a non-specific sodium channel blockage and may also affect calcium and potassium channels. And a 21 days period was used for a dose of 2,400 milligrams per day, and it was kept at this level for the remaining 6 weeks. And QST was performed according to the DFNS protocol. 83 patients were included in the analysis according to intention to treat, and the patients prior to treatment were categorized into irritable nociceptor and non-irritable nociceptor. And let's just break this down. Irritable nociceptors were patients characterized by having cold or warmth detection thresholds within the normal range, but having either dynamic mechanical or linear reduced mechanical pressure pain threshold, increased mechanical pain sensitivity, or reduced cold and heat pain thresholds, or any combination of those signs. And so these are signs of hyperexcitability. And non-irritable nociceptor was defined as having either normal values or only hypoesthesia, thermal mechanical, without any hyperalgesia. They actually found that in a repeated measures ANOVA, that's oxcarbazepine reduced the total pain by 0.7 points on the 10 NRS compared with placebo, and that the phenotype interaction showed 0.7 point better effect in the irritable nociceptor group than in the non-irritable nociceptor groups, and patients with preserved thermal sensation had a marginally significantly better effect of oxcarbazepine compared to those with a normal sensation, whereas gains of sensation did not influence this effect. Pregabalin, also a drug that is often used in treating pain. And this is a study by Olesen et al. From 2018 out of Denmark, the Aalborg University, Aarhus University Hospital, in Holland, Radboud Medical Center, and they hypothesized that pregabalin would be more efficacious in chronic pancreatitis patients who have central sensitization. And sensor sensitization would be measured by an increased responsiveness to static QST at the upper abdominal region. And this was a study of 3 weeks period of pregabalin or placebo treatment, and they gave a dose between 300 and 600 milligrams a day based on tolerability. And the QST was performed prior to starting the treatment, and they did a PPT on the lower neck and upper abdominal area on the dominant side, and they did electrical pain thresholds that were performed at the same sites where the PPT was performed, and they also used a CPM, which they did with a PPT pressure pain threshold at the quadriceps and cold pressor as a conditioning stimulus. And 29 patients in the placebo groups, which were amounted to 12 responders, and 39 patients in the pregabalin groups, which amounted to 16 responders to pregabalin. And there was a hypersensitivity to electric stimulation of the pancreatic area compared to the non-responders group. So they found that those that have a higher ratio between the neck and the upper abdomen would not be good responders. And the prediction algorithm using the sport vector machine found that only the electrical pain detection ratio between the pancreatic area and the neck had higher accuracy in predicting responders to pregabalin in these patients with painful chronic pancreatitis. Excuse me. Okay. So this is the result of the prediction algorithm, and again you can see the electrical pain detection threshold ratio over here has the highest results. In terms of patients with knee osteoarthritis, one of the very common treatment is NSAIDs, non-steroidal anti-inflammatory drugs. And Edwards, back in 2016, out of Harvard Medical School, did this interesting study, and they compared data from 35 patients with knee osteoarthritis to 39 pain-free controls. And they did QST, which was a pressure pain threshold with an algometer at the trapezius, thumb, and patella, mechanical temporal summation with a pinprick, deep somatic pain with the cuff algometry, and cold pain tolerance with cold pressor test, and CPM they did with pressure pain threshold as the test stimulus and cold pressor test as a conditioning stimulus. And the treatment was topical diclofenac for 5 weeks, and they found that patients with better CPM at the baseline showed better treatment results in terms of activity-related pain following 4 weeks of topical diclofenac. So in this case, CPM is the one that is giving us the idea who would have better treatment benefit. One of the studies that I'm quite enthusiastic about, and this is quite a new study out of 2022 by Pan et al. Out of the Vaipei Veterans General Hospital, is a study about chronic migraine patients. And I want you to pay attention because now we are finding quite a few big breakthroughs in treatment of chronic migraine, and this is one of them. And the treatment drug that was given was flunarizine, and this is a selective calcium channel blocker, and it is recommended as a first-line prophylactic treatment for migraine in the European Federation of Neurologic Societies and also the Italian guidelines. In this study, newly diagnosed and preventive treatment-naive patients with chronic migraine. So these are patients, chronic migraine means patients who have migraine for more than 50 days or a headache for more than 50 days per month. And in this case, they include patients with migraine of more than 50 days per month and for more than 3 months, of which 8 days per month with migrainous features. So, aura, one-sided headache, inability to see lights, etc. And or patients who did not respond to migraine-specific treatment were diagnosed with chronic migraine. And they had 12 weeks of treatment of flunarizine, 5 to 10 milligrams a day, and a headache day was defined as more than 4 hours of headache or the use of acute pain medication against headache. And the QST assessment was done according to the DFNS protocol in general lines and was tested both on the left supraorbital area and on the first branch of the area of the first trigeminal nerve branch, and also the ventral forearms, as over here. And the treatment response was classified as more than 50% reduction in headache days. So they had 84 patients completing the follow-up, and they were compared to 50 controls, and of them 24 was responses and 60 were non-responders. And what they found was that specifically responders versus non-responders, we can see that the heat pain threshold was one of those interesting measures that we have to keep an eye on, and also the mechanical pain threshold as well. And they did an interesting decision tree analysis that they carried out, and to identify the outcome predicted and the 3 QST parameters. So heat pain thresholds at the V1, mechanical pain threshold, and pressure pain thresholds were included in the analysis. And they found that mechanical pain thresholds of more than 158 grams von Frey filament and heat pain thresholds of more than 44.9 degrees were associated with favorable outcomes. So keep in mind, when you have chronic migraine patients coming into your office, you may want to do these 2 simple tests on them in order to see if you want to prescribe flunarizine, yes or no. Another study, this time from 2023, that is making big waves in the migraine community, is by Ashina et al. From the Beth Israel Diaconess Medical Center, Comprehensive Headache Center in London, Massachusetts, in Boston, Massachusetts. And in this case, the drug of choice was galcanezumab, and this is a monoclonal antibody against calcitonin gene-related peptide, CGRP antibody. And this was a prospective observational open-label cohort study, and they recruited patients suffering from migraine of more than 8 days per month. Patients who had migraine of between 8 and 40 days were called high-frequency episodic migraine patients, and those who had more than 50 days per month were called chronic migraine patients. And the treatment response was considered if more than a 50% reduction in headache days in a 3-month treatment period compared to the 1-month treatment period. And here we have a nice graphical image of how we can recognize responders versus non-responders. So you can see here an average of headache days per month, and we compare that to the pre-treatment average, and we can see that we have a responder on our hands. And for galcanezumab, the initial dose was 240 milligrams for the 1 month, and then they had a maintenance dose of 120 milligrams for the following month. And they performed QST on the non-inctal phase, so the patients had to be at least 24 hours pain-free, 12 hours prior to testing and 12 hours post-testing at the cephalic region, and they did periorbital and extracephalic testing. And they had criteria for allodynia, and in this case, cold allodynia was between 32 and 20. So if the patient pressed the button before reaching 20 degrees for cold pain threshold, that means they had cold allodynia, and if they pressed the button before 40 degrees for heat, they had heat allodynia. And again, for the von Frey hairs, we had normal and mechanical allodynia, depending on the grams of the von Frey hairs. And here are the results. And they found that 43 of their patients had full data, and 24 were classified as responders, while 19 were classified as non-responders, and mechanistically the presence of non-ictal allodynia, and this is reflective of state of activity-independent central sensitization, both in chronic migraine and high-frequency episodic migraine patients, raises the possibility that non-ictal may be attributed to physiological properties of central trigeminal-vascular neurons that are due to the genetic load of individual patients rather than the migraine frequency. And they found that responders were, in this case, a little bit different from our previous study, right? In this case, those that did not have allodynia and those that did have allodynia were non-responders. And this is specifically for the cold pain thresholds and for the mechanical pain thresholds. So keep this in mind again when you see your migraine patients and chronic migraine patients in terms of what test to do and what drug to prescribe. To talk to you a little bit very shortly about post-operative outcomes, and I know our time is very near, and if you have to keep going with your day, keep in mind we will send you the recording of this session, so don't worry about it, but I'll love you to stick around if you can. Okay, so Müller et al. Out of the University of Bern in Switzerland looked at patients that were undergoing 3-level spine surgery for chronic lower back pain associated with degenerative changes of the lower spine. And chronic lower back pain were patients that have at least 3 out of 10 VAS on most days of the week for at least 3 months. And the cohort consisted of 141 patients, which were followed for 12 months post-op. And the assessment of disability and pain was used using the Osprey disability index at baseline 2, 4, and 2, 6, and 12 months post-op. And QST was performed at the extremity on the contralateral of the most painful sites on the lower back, and they did electrical pain thresholds, temporal summation, pressure pain thresholds on the toe and on the lower back, pressure pain tolerance, thermal pain thresholds with a MEDOC TC2 on the lower leg, and a cold passive task with the hand in icy water. And CPM, they used the test stimulus of pressure pain threshold and conditioning stimulus of the cold pressure task. And the results were that cold pain sensitivity of the leg was an independent predictor of poor recovery with an odds ratio of 2.98. So this is a very strong predictor of poor recovery of this group. Looking at neck surgery this time, I want to present to you this study by Chen from the Fudan University in Shanghai, China, and they did they looked at post-operative axial pain, and axial pain is pain or stiffness around the posterior neck, periscapular areas, or the shoulder region, and this is a complication that affects between 5 and 60% of patients undergoing posterior cervical decompression surgery. And they had 122 patients with degenerative cervical myelopathy undergoing laminoplasty or laminectomy. And the QST consisted of temporal summation using pressure algometry, condition pain modulation using pressure pain threshold at tibialis anterior, and the conditioning stimulus of a pressure cuff, and pressure pain threshold of an upper trapezius and tibialis anterior muscle. And so PAP, post-operative axial pain, was defined as newly developed or worsening pain around the neck or the shoulder that persists at least 1 month, or persists and recurs for more than 6 months after operation. Then it's chronic post-operative axial pain. And 21 patients out of 122, that's 17% or so, developed PAP at 1 month post-op and a 6 month post-op. These were only 8 patients, excuse me. And in table 3, we can see the QST measures and their associations with axial pain at 1 month and 6 months post-op. And at table 4, we can see a multivariate analysis on the determinants of axial pain at 1 and at 6 months post-op, and at 1 month, this would be C2 decompression, preoperative pain, a physical activity questionnaire, and temporal summation, and at 6 months, it's preoperative pain, CPM efficacy, and temporal summation as well. I think this must be one of our last slides to present on the topic of post-operative pain, and this is with regard to thermoquantitative sensory testing and the prediction of an acute post-operative pain in gynecological surgery. And in this case, one of the strongest measures was opioid consumption in the 24 hours post-surgery, and they found that patients that had a relatively high cold pain threshold, so that they are more sensitive to cold, were using opioids quite a lot more than those who were less sensitive to cold. And the same is with regard to heat. So those who were more sensitive to heat used more opioids than those who were less sensitive to heat pre-surgery. Last few items before we close down this webinar, and thank you all for sticking around. Now we will talk about non-pharmacological and interdisciplinary treatment efficacy. And this is quite a big meta-analysis from the Peterson lab, and we know that Peterson, this lab from Algeburg, Denmark, do quite a lot of research regarding osteoarthritis and prediction. And they, in this case, use the meta-analysis, and there are quite a lot of meta-analysis in terms of phenotyping and QST, so have a look at those. But I wanted to present this one since it's quite new, and it shows quite nice effects for QST. And so they found, for instance, the association with post-operative outcomes for total knee arthroplasty, and they found that pre-treatment QST parameters predicted pain-relieving treatment outcomes in 81% of the surgical studies, and in 100% of the pharmaceutical studies, and in 50% of the exercise-based therapy studies. And I think I will not talk a lot about this slide because we still have some things to do, but I want you to look, please, at the different measures that were used in those studies. And if something like this is something that you plan to do, please look at the measures. You can see that a lot of pressure pain threshold is being used, of course, very mechanistic for such a musculoskeletal pain. Also, a nice new study, I think out of 2022, from the McGill University and the Edgeworth Family Interdisciplinary Center of Complex Pain. And in this case, these are juveniles with chronic pain, and they had looked at the medical records of 208 female juvenile patients that were enrolled in an outpatient interdisciplinary pain rehabilitation program. For 106 of these patients, there was QST available, including CPM data at intake, and for 102 of those records served as controls, as they did not have any QST or CPM data available. And in their study, they wanted to know, does the information of QST, provided by QST, affect in any way the treatment course that of the prescribing physician? And for those that did have QST data and CPM data available, you can see below the type of phenotype, and also the first line and second line type of treatment that was chosen by the treating physician. And what they found is that QST and CPM evaluations, when those results were not available, the clinicians chose the medical treatment according to the treatment guidelines of those specific conditions. Okay, so whether it be headache or widespread chronic pain or complex regional pain syndrome, and we have different categories. We have categories of different types of drugs, and under other drugs, they included mainly magnesium supplements, melatonin supplements, oral clonidine, and topical non-NSAID creams. Okay, and the authors concluded that a mechanistic approach may reduce the use of potentially unnecessary treatments without affecting the clinical outcome. So all of these patients, be it those that had QST done and those that didn't have QST done, were more or less released from treatment at the same time, and release was initiated when they reached pain out 3 out of 10, more or less. And there were also, of course, other considerations since these are juveniles. But you can see that for those that had QST available, there were more other types of drugs, but much often less opioids, for instance, in secondary chronic pain, and less NSAIDs, and also less interventions. So could we possibly treat people better, having the same outcome, but without using very heavy drugs and using interventions? And this study suggests we may. One of my last slides. In this slide, and I'm a little bit enthusiastic about this study because this is a study by Belomo from the Wayne State University and the University of Michigan. And why am I enthusiastic about this study? Because this is a study with fibromyalgia patients, and they are looking at different types of psychological intervention. So we are talking about emotional awareness expression therapy, and this is a therapy that was developed to directly address factors that by engaging patients in emotional processing and corrective emotional experience and stress reduction. And the patients in this study had either education about fibromyalgia, or a cognitive behavioral therapy, or this emotional awareness expression therapy. They had did pressure pain tolerance testing on the thumbnail, and they valued the group by normal tolerance according to other published data that they had, or low tolerance for those that were extra sensitive to pressure pain on the thumbnail. And they found that those patients with normal tolerance had much better efficacy of the emotional treatment than those with the low tolerance. And you do see some treatment efficacy here in PPI severity, but this is an interesting finding in personalizing even psychological treatment for fibromyalgia patients. And in this very recent study by Morris et al. Out of 2022 from the Vanderbilt University of Medical Center, they looked at youth with functional abdominal pain, and they participated in a controlled trial of cognitive behavioral treatment or education treatment. And for 12, and they had a 12 months follow-up, and this was, I guess, during the COVID pandemic, because all of these treatments were online and that were done with these patients. And the QST, and for the QST, they used the TC2, and the heat pain thresholds and heat pain tolerance. They did it, and they did also temporal summation, and the CPM was tested with contact heat using the CSA2 as a testing risk, and calibrated at pain 60 temperature and a hot bath at a conditioning stimulus. And the patients also filled questionnaires in terms of pain interference and gastrointestinal symptoms and abdominal pain. And they found that pain threshold, pain tolerance, and temporal summation at the baseline were not associated with treatment outcomes. CPM, however, was associated with pain interference, such that patients with effective CPM enjoyed a significant reduction in pain interference independent of the treatment, while patients with lower CPM did not have this reduction in pain interference after treatment. And for those that still stuck around, we are concluding our webinar for today. And I have to conclude by saying that there is a lot of evidence mounting on the usefulness of QST and the use of prediction of treatment efficacy. And for those involved in research, keep on going. We are looking forward to it. And I think at the end, what really matters is that that there is a way to better help patients suffering from pain or other conditions. There is also a great variation in QST methodology, and keep that in mind. And it's a significant in prediction, and keep this in mind that QST methodology is an important one, and there may be different methodologies for different mechanisms. And one of the things that I am most enthusiastic about in the studies that I presented is the very strong evidence and indication of phenotyping treatment responders in preventive migraine treatment. So this is something that I'm quite enthusiastic about, and I hope that we will see QST being used in the doctor's office in order to choose what treatment we're going for. I will conclude my presentation by thank you very much for attending, and I'm open to questions. Let me find where we are at, and if you have any questions, please ask them in the Q&A panel. And if there's any remarks or anything that you want to ask or say, and you would like us to, or like me to write to you, please fill that into our survey afterwards. So thank you so very much for sticking around and being with us, and I hope that you enjoyed this webinar. I enjoyed making it, and it was a very, very hard choice, all of those interesting studies, and there are many more around. So if you are researching a specific topic, please look into what already has been done and keep on going in that line.